Dr. Tro. Thank you for joining me on the Uncommon Living podcast.
Thanks for being here. We were talking off air about sort of similar viewpoints we have and some similar practices I think we maybe both do in life. So it's nice to meet you. Nice to be here. Hopefully I'll be seeing you in the West Coast pretty soon. So I'm
I'd like
looking
that.
forward to that. Yeah. We'll do some cold plunges and eat some steaks, seed oil-free steaks, and
Exactly
we'll have a
right.
fun time.
I think that we've noticed one another on Twitter when you say that we have similar views. I've been following your tweets, and I'd say that we intersect on nutrition, metabolism, and public health policy, which is why I'm honored that you're joining me, because I want to ask you to share with our audience your critique of what we might call traditional medicine, which has only been the tradition for, I don't know, 100-something years, but allopathic or centralized medicine. You specialize, if I'm getting this right, in weight management and weight loss. And there's a lot of bad advice out there that I think in your social media presence, you're trying to correct. Will you tell us?
Yeah. So I think it's very easy to see the hypocrisy. And I guess you'd have to understand a little bit about me if you're going to understand what motivates me. I think it's important for people to understand who are they listening to. So I'm a board certified internal medicine doctor. I'm also board certified in obesity medicine. I sit on the board of the Society of Metabolic Health Practitioners, and I'm also an advisor to the Coalition of Metabolic Health. I've worked with CMS and HHS trying to, I do not work there, but sort of given my input on how to deploy our guidelines and our new dietary guidelines and how really to make medicine great again. And I think to understand my own nature is important. So I often share the story that I was an 8-year-old. 8 years old, I was already obese. I was probably 150 pounds by the time I was 8. By the time I was 13, I was 210 pounds. I had watched my mother be gaslit by the medical system. So my mom also struggled with weight. My father too. Both of them really struggled with weight. And I remember distinctly being an 8-year-old, having her be awake at night, very late at night and anxious because she was prescribed fen-phen
Mm.
by her doctor. And I remember going to Weight Watchers with her. I went to Weight Watchers at a young age. Uh, I had a photographic memory of calories. I could recite them for you, the calorie counts of various foods. And so that information wasn't helpful to me. And I got to 13 years old. I remember going to my primary care doctor's office, sitting in a waiting room for an hour and a half. It seemed like an hour and a half. Maybe it was an hour, an impatient 13-year-old kid. And he put me on the scale and he said, "You're 210 pounds. Gosh," he goes, you're fat. And I remember thinking to myself, he's like, "You got to lose weight. You're going to be fat like your family." My whole family struggled with weight issues. And that was the moment. That was the origin story, right, of the superhero. Wanted to be a doctor at that moment. And I remember thinking to myself, this piece of shit just made me wait an hour in his waiting room, and he could have put a bike in his waiting room instead of, these chairs and these magazines. I could have been on a bike. Gosh, now I could have been in a cold plunge in that waiting room, right? So I was like, what? Like, this guy has to be literally the laziest piece of shit to be telling me that. I mean, this is my 13-year-old angered self.
And I
And I
should
was like,
clarify for our audience, Tro
yeah,
grew up in New York. On the
yeah,
East Coast around New York, there's a certain lexicon, the way 13-year-olds think.
yeah. Well, I don't think I've matured in that way. But so I remember just thinking to myself, like, this is not the way it should be. Right. So I had an ideal at that point to change medicine, and it was like, there's got to be something better than this. My mom was further gaslit after Weight Watchers didn't work, after Fen-Phen didn't work and was recalled, bariatric surgery, Ozempic, ba 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 ba, and it hasn't stopped. And I think that's what brought me into medicine, right? This bit of like the current standard is not enough, and we need to radically change. So that's what brought me into medicine. But then I became what I feared the most. I went to a Yale affiliated internal medicine program. I became the chief resident, and I was a 350-pound, you know, top performing physician, top scoring on my board exam. I became everything the current system wanted out of a doctor, right? Scoring well on board exams, patients, surveying me very high to the point where, I was selected to be chief resident. And yet I knew nothing about chronic disease management, nothing. I was 350 pounds, chronic disease reversal.
Yeah.
So that's where my origin story started. I went in as an angry, kid wanting to be a doctor, and they made me one of them, and I became one of them, and I did what they wanted better than them. 90th percentile on my board exam, chief resident in an Yale affiliated program. Did I did what they said, and it led me nowhere. So the light bulb moment when I was like 350 pounds, struggling, every part of me hurt. I was hypertensive, just brain fog. Well, I felt like I was a shell of myself. I was not, like, as if I was, shackled down. I mean, the best, way I could describe it is, imagine being like, I don't know if you've ever seen that movie Matrix, where Morpheus is captured and he's drugged up and he's like connected, to the system. That's what it felt like, and so then I was like, let me just go about chronic disease like I would anything else. And my wife really helped me focus on that. And she said, like, you can figure this out. So I went to chronic disease. I picked something small like weight loss. And I said, let me learn the data so that I can not believe what the mentors are saying I have to study, what the American Board of Internal Medicine says I have to study. Let me just go back as if it was pneumonia, look at the interventional trials, this versus that, what does better, and then do my own comparative analysis, look at all the different trials and see what is the best way. Just weight loss. Because I was 350 pounds and miserable and I wanted to lose weight and I saw my whole family suffer. So they gave me the ability to analyze data. They gave me the ability to understand medicine. And then you see that everything is a freaking house of cards and a bunch of lies. At the time, the food pyramid, supported grains and seed oils basically, and sugar. Processed sugar was really, and honestly, you have to view our modern food system as completely processed, including the agriculture. It's been hybridized and bred to the point of being sugar popsicles. So it's like there's no escape from our from our food environment. But, low carb diets just did better. It was that simple. So my first foray into, challenging the orthodoxy was let me just see what our current guidelines are, what our current recommendations are, and the data supporting it. And then once that light bulb opens, you just go down the line and apply the same analysis down the line. And it's the same conclusions every single time, chronic for anything from vaccine policy to public health measures to chronic infections. It's the same nonsense. It's basically ignoring data, for the sake of homogenized observational junk. And so once you understand, and I don't know if, sorry guys for the listener, if this is like a tough, to follow on, but it's just junk science. And then, you have the added problem of interpreting junk science from the lens of human interest, which they've taught you that data and peer review creates like this unobject, like all of a sudden all your biases disappear. Like imagine, I know you read some of my papers. Imagine thinking that my bias just disappears, right? Like, no, right? I have a bias, I have a mission, and and once you understand that medicine from the top most effective, most known journals like the Lancet,
Oh my God.
right? And have an objective,
Are
and
you
like
sure
the New
there's
England
still a
Journal of
journal?
Medicine.
Or
Yeah,
are they
exactly. Like
a political action committee?
correct. All of these, they're all biased, just like me. Once you understand that you're looking at data through that bias, like it's not just that the data is a bunch of lies in a house of cards. It's the implementation of this data and the fundamental fact that we each have, these biases, whether implicit or explicit. And I'll tell you, for most of nutrition medicine, it's explicit.
You are among a set or a cohort, a generation of physicians and scientists who are now telling the American public that everything accumulating in public health and nutritional advice from the 70s up to the late 80s and into the 90s was a lie. And until the COVID lockdowns, I think it was really hard for the public to accept that these institutions, the universities, the journals, the federal government institutes of health were abject lies. But now we have Robert Lufkin's book, Lies I Taught in Medical School. We have Marty Makary saying blind spots. He's a little more gentle about it. He says these are decades of misconceptions that have persisted despite the data. We have Abraham Morgentaler saying, you know what? Testosterone doesn't give you prostate cancer. We have a number of people at this leading edge who are finding an audience among the American public. If calories in, calories out was the truth, then why doesn't it frickin' work better? So I've only sort of hitched my engineering wagon on to this wave of physicians and scientists out of my own personal experience. For me, it was 25 years ago when my son was diagnosed with type 1 diabetes. He was 6 years old, and it was the same thing. I had just defended my dissertation. I knew how to work with data. I kept scrupulous journals, and his blood sugar data didn't agree with what the dietitians and the endocrinologists were telling me. That's when I knew I was going to have to go my own way.
Yeah, and look, I think so. Like, if I'm being gracious to the existing paradigm, I like so 100%. I think what you're saying is the truth. This is a bunch of a bunch of lies on a house of cards, right? So, but I think there's probably and it's an inflammatory way of speaking. So I'm always mindful. That is the truth, right? It is an aspect of the truth. There is another truth, that it was a bunch of best guesses and they were the experts, right? Or they were,
No. That's not another truth. It's a benefit of the doubt. The problem with that is the doubt has been removed by decades of data. In the 70s, perhaps there were doubt. People were saying, oh, you should reduce your sodium intake to get your blood pressure under control. It was an idea. Well, it turned out to be wrong. You should reduce your saturated fat and your cholesterol intake so you don't die of heart disease. That turned out to be wrong. We now know we're not in doubt anymore.
so I'm not in doubt at all, right?
Right.
I don't have doubt of my interpretation of the literature, the conclusions that I've come to, and how I frame those conclusions. I can certainly imagine a world, let's just take like metabolic syndrome and obesity, right? And I'll not create doubt, but give another way of looking at it. So at this point, calorie for calorie, lowering your carbohydrates improves metabolic syndrome, right? This is calorie for calorie, lowering your carbohydrates improves glycemia with or without diabetes. So, and these are like indisputable facts, right? And so, you know, I wouldn't say it's indisputable. I would say it's so largely generalizable that it's truth. Now, but back out 5 decades ago, right, where novel oils aren't like ubiquitous. where people are still eating, homemade foods. Like literally, the slaughter was the animal was killed. That you're churning the butter, right? So imagine that population. It's so far from our ability to imagine what we have right now. The contaminants, weren't an issue. Microplastics wasn't even a thing, right? Blue light wasn't even a consideration, right? There was barely incandescent light. And when incandescent light we even know is healing compared to blue light. So the thing is you go back and you think about, let's run this simulation in a different population. Would I have the same issues of carbohydrates? I can design a population where the conclusions from today don't matter,
Mhm.
right? A thin, healthy, oh my God, I don't want to say unvaccinated, right? No, not exposed to novel lights, exposed to the modern environment, not exposed to our engineered foods, literally and our nutrient depleted foods. In the 5 decades, the magnesium levels in our crops have decreased like 30, 40%, right? So, so you, I think like if I was a scientist 7 decades ago, looking at the data from their population, the bedrock of my conclusions would be maybe different, right?
I'm so old, Tro, that I used to walk home from elementary school. This is first grade, so I could have lunch with my mother at now, we feed the kids pizza with ketchup and
Yeah,
seed oil French fries and things. We feed them at school. But I've seen a lot of changes. If you're going to be gracious, in the 70s, people were suffering under misconceptions that were deliberately propagated by the tobacco companies who had distorted the data, deliberately lied to government officials and the populace to make people think maybe cigarettes don't kill you. We were worried about, the China syndrome and 3 Mile Island. They built a school in Love Canal, New York, on top of a chemical waste dump. And nobody cared until 60 Minutes said, hey, why are all these kids getting leukemia? In the 70s, it wasn't a to people that maybe the human body is not supposed to eat partially hydrogenated cotton. They were
bingo,
bigger
bingo.
issues.
So that's what I'm saying. So I think the bedrock of like what scientists were expected to know. Like I can imagine being a scientist in 1960 and saying, "Gosh, I really don't know." I think the problem happened when they saw these small signals and said, "We definitely know." Right? And then I'm guessing to some degree it was a bunch of useful idiots, right? Useful idiots, right? Like the industries, like that message makes sense for us, So you get this sort of, the people courageous enough to make ignorant conclusions, right? And maybe not humble enough to say, I could be wrong. Those people are, propagated. And then you go fast forward seven. And if you look at public health, we're talking about people who were literally infecting other people with syphilis, right? Like
Yep.
those are the minds
On
that are in
purpose.
our public health on
Yep.
purpose, right? So if you look at what happened, it's just rewarding authoritarianism and somewhat malicious people and somewhat people without humility and people without scientists without a bit of creative thinking, challenging thinking. And then it just gets worse and worse as you go. I mean, you know, like, look, I'm going to be clear with my biases. When I was an intern in Yale, in the Yale affiliate program, medical intern. This was in 2010. So it's fairly new, right? So it's 2010, and CMS puts out a new authoritarian principle, right? And that authoritarian principle is you must report. Actually, it was 2008 when they did the first set. CMS, which is like the body, the Center of Medicare Services, right? And they're the body that pays for Medicare and Medicaid largely. They said in the early 2000s or mid and late 2000s, if a hospital wants to continue to get paid well, they're going to have to report how many of their patients are getting vaccinated or have taken the pneumonia or the flu shot,
Hmm.
right? And it seems like it's like a noble thing. These things work. We want people to take them. And so, let's make sure that people are actually checking and let's reward people for actually checking, right? That's what CMS's idea. The next year, they said, we're going to tie your payment to the amount of people who get this treatment, right? And so this is where it's the hegemony started, right? First, it's like, tell us, are these doctors having the conversation enough that it's getting taken up? And then the next year was, we're going to penalize you if it's less than 90%, right? Which, these are small little like chips away at the principles of patient autonomy, shared decision making, and non-paternalism, really, in medicine, which is I know better. Here I'm the CDC, and take your syphilis pill, and so
The examples are everywhere. You have the American Heart Association being paid by the ultra processed, like the breakfast cereal companies, who are now owned by those tobacco companies, to endorse breakfast cereals and tell the world that something like Cheerios is heart healthy. This
yes,
is quite the corruption when you talk
it get
about bias.
it gets worse and worse. So in 2010, CMS said, "Well, we did this with patients. We should do it with healthcare workers." Right. So then they said, we want to know, how much to each hospital. They said, if you want to get paid, tell us how much your employees are taking the vaccine, right? The flu shot, and they did the same thing. If you want to get paid as much, or you can take the penalty and not do it. What would any hospital administrator do?
They got to push
Right.
the vaccine.
Right. They got it. They
Yeah.
have to push it because this is a business. They are saying this is right. It seems right. We got to do it. So it's like
Even if it's a
these,
nonprofit hospital, they would make the moral argument that they have an obligation to reduce healthcare costs. And if they can do that by making themselves eligible for these government patients, isn't that better for the institution and for their own patients? It
correct,
creates such a twisted incentive structure that you start
correct.
making moral arguments for the immoral action.
Bingo, 100%. So the next year, CMS, and this is me as a medical intern, says, we are going to penalize hospitals that have under 90% flu uptake rate. And every single hospital throughout the country basically removed the personal exemption from taking the flu
Yeah.
shot. Now, I become an intern, and I go in, and they're like, "Well, you have to take the flu shot." And I said, "What do you mean have to? Like, what do you mean have to? Like, show me the data. Show me that you're going to save my life's going to be saved. I'll sign up. Like, just show me the data. I don't want to take your shit just because you told me to, right?" And you look at the data, Cochrane. I mean, Thomas Jefferson from Cochrane is a saint. He is a saint. He has been challenging the orthodoxy. You
We're talking
know,
about a modern day physician whose name is Thomas Jefferson. We're not
yeah.
talking about, a founding father.
Yeah, yeah, yeah. Sorry. Thanks for Tom Jefferson. So yeah,
Yeah.
Tom Jefferson, Dr. Tom Jefferson. He is an epidemiologist and a family medicine doctor. He worked at Cochrane's for a number of years until their controversial issues of late. And he had all the guidelines written out. He had done all the meta-analysis work, and basically it was a bunch of BS. Like maybe if you're older and you have significant comorbidities, it's potentially beneficial. And just about for anybody else, there's no clear benefit, even in healthcare workers. There was a study at Hopkins looking at head to head whether you took a flu shot or placebo, even if it just reduced work days. And they couldn't even prove that it reduced work days. So I'm analyzing this data and I'm like, guys, I'm not going to take this. Right. And this is Yale. This is as an intern. They sit me in and they're like, is your wife pregnant? And I said, yeah, my wife's pregnant. Yeah. And they're like, well, what if she gets the flu and dies? How are you going to feel? And I'm like, that would be unfortunate, but that doesn't change the meta-analysis data.
This is coercion, right?
So I knew at a young age what the system is capable of, and I didn't take the flu shot. I didn't take it, and they said, "Well, you don't have a medical exemption and you don't have a personal exemption." And I'm struggling with this, and I'm like, and there's a religious exemption. Now I'm Christian, right? I was baptized. I don't go to church as often as I want. So I picked up my priest. I picked up the phone and I called my priest, and he's like, "You've never called me before. What's going on now?" And I said to him the truth, which is, I am in an incredibly difficult situation and I need spiritual guidance and I need moral guidance. I cannot consciously do this, right? It's against my consciousness to do this. It doesn't make sense to me. Gosh, I said, I can't do it. And my only way out is to say there's a religious exemption, but there's no specific doctrine in Armenian Orthodox Christianity that says you can or can't do flu shots, right? And he goes, "You don't need that." He goes, you need to say what it's doing to you. It's against your consciousness. It's disrupting your relationship to God. And I'm happy to sign a letter for you. And he signed a letter for me. And for over 15 years, I had a religious exemption, and I didn't take the flu shot. And I was ostracized. I mean, this was like you know, who is this crazy guy? Eventually, they made me chief resident just because, like, I wouldn't give them any other reason to ostracize me. I just wouldn't do it.
We should also clarify that your wife did not die of the flu.
She did not
She's
die.
healthy. Your children are doing great.
God is good. God is good. Look, yeah, yeah. So if you look back, and some of those people who not ostracized me but pressured me and coerced me, these were people who I love to this day. They're one of the a couple of the greatest mentors I've ever had. People that I've turned to in very difficult situations afterwards, for my own self, for my house staff when I was chief resident as an attending. And these are not bad people. Just they're also have a point of view and a way of looking at things. So one by one, look at the CDC recommendations for diabetics. You see that they say 60% carbohydrates. That's been taken off. Thanks to
Enormously
this
high.
guy. Yeah,
Yeah.
thanks to
Way
this
to
guy.
go.
And you look at these authoritarian measures, and it's hard not to get angry, right? It's hard not to be really upset. You look at the COVID nightmare, and what happened to people, and it's hard not to get angry. And I know people want to get angry, and they should. And there's somebody up the chain somewhere that knew better and or was malicious. We like it looks terrible the further you go down the rabbit hole. But I think even at the level of like this hospital with the chief safety officer, chief medical officer, right? My program director, none of these people were malicious. And they have cared for me and helped me, and it's just stuck in a set. Most people don't. It's too uncomfortable to challenge the fact that you don't know what's right. And these financial coercions are largely why we do the things we do.
It's more than financial coercion. As human beings, one of our deepest fears is the social judgment, the fear of being cast out of the tribe. This isn't really a modern, technological situation, but we're not biologically suited to our social media worlds. In the university, our careers live and die with peer review, whether it's a grant or a paper. It sort of keeps all the faculty at the emotional maturity of an eighth grader, where nothing is more important to them than what their peers are doing. At ASU, where I teach in engineering, some of the same pressure was applied, but worse. We weren't talking about the flu vaccine. Because I was one of the more vocal faculty opposing the lockdowns, I wound up in trouble with the provost office. they told me I was no longer allowed to talk to the press. I was scared, and so I agreed. What a mistake.
Yeah, and I get it, and I get it, right? I trust me, I get it. And what happened to people, with their jobs being taken away? What happened to a generation of people feeding their kids slop at school and in colleges, and and being fed, experimental drugs passed off as safe and effective for generations. And it's hard to do when you're the real food. But let's just talk about the flu real quick. You go back to 2015, the Bill and Melinda Gates Foundation did a huge study on the flu shots in South Africa, giving them to pregnant women. I mean, it's evil, in my opinion, to do that. Not a proper disclosure was given. Anyway, they did it, and the end point was to look to see if it prevented flu in the offspring, right? And what they found was, after giving a flu shot to, I think, 2 or 3,000 people, it didn't save one life. So the number needed to treat for this, hallucination of an idea that the mom will get the flu shot, pass antibodies to the kid, and the kid will get these antibodies. And then, it's a hallucination. It's not been shown, right? They disproved it. Right. So I was like, look, they even ran a placebo controlled trial for flu. And I said this for since then, 2015 years. I'll give you a counterpoint that the listener, hopefully they're they don't hate me for saying this, and I'm not contrarian. I'm just saying this is the data. A group in 2020, well, starting in 2018, and they published their study in 2021. It was a group of cardiologists that did a placebo-controlled trial with true placebo and the influenza vaccine in people who just had coronary artery bypass graft or stent, which is surgery for heart disease, basically. And they showed that you needed to treat about 20 people with the flu shot to save one life. The absolute
Right?
risk reduction was like 2%. It was so unignorable, right? Now, I want to juxtapose this to what I said for the decade before that. The decade before that, if you looked at flu and cardiovascular mortality, flu shots and cardiovascular mortality, it was a cyclical pattern, right? The flu shots actually decreased cardiovascular mortality in years where the match strain was less good. So when the flu shot, right, because the flu shot we don't always hit, it's 10% to maybe 50%, 60% at best. Over the last 2 decades, when you look at the match rate of the flu shot to the circulating strain. So they went back and analyzed cardiovascular mortality in people who got the flu shot, and the mortality benefits were better retrospectively in years where the strain was not a good match. In the 10% years, if you took the flu shot, your cardiovascular mortality really improved a lot. And in years where the strain was matched well, it didn't improve that much. And I'm thinking to myself, this has to be healthy user bias. This
Yep.
has to be,
Yep.
right? This has to be the fact that they're just, people who are on top of their health going to get the flu shot. This has to be. And then these cardiologists are like, well, let's settle this once and for all. They do a double-blind, placebo-controlled trial, and it shows this massive reduction in cardiovascular mortality. So here I am, Thomas, and I've not taken the flu shot. I've gotten religious exemptions, and I have to assimilate this data, and what do I do? This is an interventional study that cannot and will never be done in a huge amount of people, so well done, multi-centered, worldwide. And this is a private, not sponsored by pharma at all. These are just a group of cardiologists who did it. So here I am. I have to be humble and say, gosh, I don't know.
Hmm.
Right. And even though I would never take the flu shot, I, you know, my dad has a stent, and I have to talk to him about this study. How do I reconcile it? So I think to some degree, we have to be simultaneously angry, right, at all of these terrible, terrible people. We have to be angry at them, and we really have to replace them or humble them, right? They have to be replaced or they have to be humbled, either one of those two. But it's freaking hard to be them. It's so
Anger
hard.
can get us going, but nobody wants to be around someone who's angry all the time. Anger might get us started, but it's not a solution. The irony, we spent a lot of time talking about the flu vaccine. The irony is infectious diseases are not our problem right now. The problem in the United States with health is chronic disease, and it originates in the metabolism. So by the time I had to apply for my religious exemption at ASU for the COVID vaccine, I wanted a science exemption. I had already read Suzanne Humphrey's book. I'd already looked at the data over the timelines, and I realized that it was the environmental engineers like me. It was clean air and clean water and basic sanitation that was reducing the fatality rates with all these infectious diseases. And so you see mortality from measles. You can pick any one of these things and how it goes down. But the problem is chronic diseases are all going up. They're going in the other direction. Jay Bhattacharya points out that life expectancy in the United States peaked somewhere around 2014, and it fell off a cliff after the vaccine rollout. We aren't going to turn that curve back around without addressing this metabolic syndrome that you were talking about before. And the advice that we're getting from our august institutions like the American Diabetes Association or the American Heart Association is still terrible. They're the people who presided over this increase in metabolic syndrome. And I know, because I read your papers, that you take a different approach. And it's not coming out of anger directed at policymakers, it's coming out of caring for your patients. Will you tell us about what you do?
Yeah, I'd love to. Thanks for asking about the papers we've published and the clinical work we're doing. I want to come back to the just to sort of wrap up the fine. We told all these stories about medicine and to corrupt, I think, institutions, right? Like the AHA and the ADA requires two really key things because these are fairly corrupt institutions.
Yeah.
And I highly recommend people be very cautious adopting. It's not to say everything they do is wrong, but you have to be able to analyze them under the lens of one, corporate sponsors, right? Which doesn't necessarily mean stop what you're doing and discard everything. It just means you have to be cautious. It means they have blind spots they're not aware of, right? From the majority of them, or they have blind spots they're aware of and they're ignoring, right? And either of those two should give pause to an outside party analyzing their information, right? Um, and and I'd say, if I had to guess, the majority of people in medicine believe that they want to do good, and scientists believe that they want to do good, right? So, and very few people, I suspect are, necessarily bad actors. But what it requires a couple of things: lack of humility. If it's not evil, outright evil, which it very well may be in very select few, I just haven't seen it. I haven't seen that play out in the thousands of medical students and residents and doctors that I've interacted with. I think the overwhelming majority, it's not evil, it's this tribal, I just don't want to upset the system. And it's a lack of courage and a lack of vision and a lack of humility, right? And that's what these sort of organizations prey upon. Like the dysfunction preys upon a couple of things, right? It's the financial incentives. It's in this, corporate capitalistic, which I'm very happy and proud to be in, right? I myself am a corporate entity. I have a corporate entity and I love capitalism, but we have to acknowledge that you need greed, you need a groupthink, right? And you need a lack of humility,
Hmm.
right, to really institutionalize evil, right? And you need that fear of being different, right, to be so pronounced, right? These are the things that are needed. So when you're looking at, when you're looking at the ADA or the AHA, this is the lens you need, right? One, do they take money? It doesn't necessarily mean anything by itself. Two, can they admit mistakes, and how do they admit mistakes? And if you're looking at the FDA right now, it's like the most glorious time. We messed up. Consider HRT. We messed up. There may be a thing called chronic Lyme. We messed up. This could be biowarfare. We messed up, right? So look for humility and look for how they deal with challenging ideas, right? How they deal with challenging ideas, how they deal with change, how seriously they take it, and the financial incentives. I would look at those things when you're evaluating these institutions, and when you're dealing with these institutions, I think that's how you should determine your degree of trust. And if you have 4 to 4, where you have the pervasive, like if their members are going to lose their jobs for dissenting, right? You have to understand you're in a groupthink environment, right? If their opinions cannot financially disagree with their donors and how they make money, right? I think you have to analyze that. And I'm guilty of this, right? And so these are the things you got to pay attention to. Now, coming back to toward how did we stop this?
There you go.
Right? How did we stop the fact that dissenters need to be embraced? Dissenting needs to be embraced. How do we align the financial incentives with the people that we serve, not the people that pay us, the people that we serve? How do we create a scenario where we need to challenge our own assumptions, right? We need to challenge our own assumptions. And that's simple. We figured it out, right? We figured out how to do that, right? We put our money where our mouth is. And this year, all the data, I'll talk to people about all the data and stuff we do. I don't think that's my crowning achievement. My crowning achievement is this year, we started offering in our medical weight loss program a guarantee. Okay. And it's not a guarantee that we're going to get certain outcomes. It's if you buy into our assumptions, you stabilize your glucose. Okay. You make ketones. Okay. And you show up, listen to our advice, consider our advice and try to implement it. Just show up is what we're measuring, right? If you do those 3 things and you do not lose weight coming in from a BMI of 40 or an A1C of above 7, you will get free care.
Mm-hmm.
Right? So I cannot make a more clear incentive to myself, right? I will not get paid if I do not serve you, right? If I do not serve you. So every single doctor, every single health coach in this practice is now 100% financially aligned with getting the outcome of reversing sickness, right? Chronic disease. So I think that's our crowning achievement. And we did this in a way that's legal and ethical, right? Where I'm not guaranteeing you a clinical outcome. I'm saying I will eat my words and give you 6 months of free care on me if you do what I asked and I don't help you, right? And think about that. It also puts me in a position to immediately learn more, and change. So that's our crowning achievement. And we did this with the employers. So the studies you put out are from employers that hire toward health. They hire our company. They say, get our employees healthy, get their medical spend down. And that's very easy for us, right?
Mm-hmm.
We look at the system and we're like, look, there's 4 points to target. Okay, people don't have access to their doctors, so they need something easy to prevent them from going to urgent care or going to an ER. So one easy way to reduce spend is just being text accessible.
Mm-hmm.
Okay. Hey, I have left shoulder pain. Should I go to the ER? Well, does it hurt when you move or is there chest pain? Well, if there's chest pain, maybe go to the ER, right? If it just hurts when you move, well, that's not really cardiac so much, right? It's more musculoskeletal. Avoid the ER. We'll see you. We'll get that evaluated, right? That's one area of arbitrage, right? Preventing people from going to the ERs and urgent cares out there that have all this price bloat. Another arbitrage is the hospital systems. The hospital systems and the insurance networks basically have increased their prices so much that it's crippling the entire economy, to be honest with you. It's like
Agreed.
this. So we just avoid them. Like the hospitals are buying practices like us because we generate labs and images for them, right? And then when they get labs and images, they get that markup and the facility fees when you go to them. So we just keep people away from the hospitals. Super easy, right? The hospital systems, we have contracted rates for imaging and labs all throughout the United States. Okay. And you wouldn't believe it. Like $150 worth of labs, let's just say $400 worth of imaging and labs with us. If you went to a university center, it would be like $1,500, right? So we're immediately helping the companies with that arbitrage. This is just financial. Forget the fact that the patient gets immediate access to just text, bypass the waiting, bypass the facility fees, bypass all the nonsense, right? And the days lost gain there. So that's all the money we save from just it's an arbitrage. Like get away from the insurance companies, get away from the university hospital systems and the corporate owned entities, and get them away from the ER and urgent care where they didn't need to go. And the last part is the medications. If you have patients, nobody wants to be on medications, or at least, 30% of a workforce is on chronic medications. About 1 out of 3 to 1 out of 5 of those wants to come off and is ready to change. So if you just target those people, right? Like, hey, we can help you get healthy and get off meds that you don't need, right? Come see us, right? When you do that, you save the companies about 2,000 to 4,000, depending on their drug spend, while the employee gets healthy. And they chose to be in that. They're volunteered, right?
So
It was
you
their
call this
choice.
de-prescribing. Someone's
Correct.
on a prescription, and because they adopt, if I understand this right, new behaviors or new lifestyle choices, they no longer meet the criteria that would justify that prescription?
Correct. And so many medications. So this is the last arbitrage. It's an arbitrage against inappropriately prescribed medications, and pharma, right? Because the costs are so high. So this is just an arbitrage game. It's all financial systems, right? This is what we're doing. And our clinical work is easy. Fix the patient in front of you, help them. Like that's the
For
easy
example,
part. Yeah.
reverse type 2 diabetes. And this gets them off of metformin or gets them off of insulin if they've been
Yes.
taking that.
Yes. Our rate of diabetes reversal is coming on 60%. We just published a poster on this, and we'll have a paper out soon. Our average patient in our program at 1 year, so sustainable results, is 43 pounds of weight loss, on average, coming off about $2,000 worth of medications, about 2 or 3 medications on average, and their blood pressure comes down 17 points. And you think, okay, you lose weight, you fix your diet, blood pressure and diabetes reverse, fine. But that's not just it. Reflux goes away, mood gets better, SSRIs can be tapered slowly
Mental
and,
health.
titrate. Yep, exactly. Mental health improves. The average person coming into our program in an employer setting feels unwell 20 days, 20 days out of the month, they feel unwell. And at
Gosh.
6 months, they feel unwell 2 or 3 days out of the month. So it is when you are ready for change and you're met with a system that's incentivized to actually get you healthy and get you off medications that you don't need, right? It's so if you look at what we do, it's not the secret sauce isn't metabolic health. It's actually financial arbitrage, right? This is what we do. It's all arbitrage. I don't serve you, I get penalized, right? I don't prevent you from all the bloat and the corruption in the system, I get penalized, right? So my crowning achievement is not all the studies. You can read all the studies I do and all this and that. It's nothing.
So
It's
the
just
innovation is in the
incentives.
business model because it
Bingo.
corrects the incentives. Now it directs your creativity and all of your clinicians, their energy is going to solving the patient's problem instead of working the spreadsheet so that they can maximize the claims they're sending to an HMO or Medicare or whatever.
Correct. Yes. Like, hey, my blood pressure's high. Well, come in for a visit. That's nonsense. Here, we're going to mail you a piece of equipment. We can track it remotely, asynchronously. Never come in. Our goal is to help you not need this. If you need it, we'll prescribe it, and we'll be easier, quicker, and able to. In an average corporate setting, we'll stop. Like, let's say for every 100 meds we stop, we start 12.
Yeah.
And this is just honestly just doing good medicine. That's it.
What do people do if they suffer from chronic hypertension? What do they do that helps them resolve that would drop their blood pressure 17 points, for example?
Yeah. So the most potent way, and there's head-to-head studies looking at the DASH diet versus low-carb diets, and it's very clear that low-carb diets are superior to the DASH diet for lowering blood pressure. With this caveat, I mean, Nobilize. This is the Nobilize, right? 1 out of every 5 people are salt responders, right? They have a poor excretion of salt, and so salt intake, like the salt excretion is controlled, right? So acute salt intake raises their blood pressure, right? And 1 out of 5 people have this. So a very quick thing is out of every maybe like 1.5 out of 10, but whatever. Let's just say 1 out of 5. So every 5 people you have with just have them do a salt, elimination experiment for 1 week. Lower your salt, measure your blood pressure, don't change anything else. Add salt back robustly 2 to 5 grams a day and see if the blood pressure changes. If you don't have a blood pressure change, disregard the low salt dogma, right? 1 out of 5 will have that.
Will low salt modify insulin sensitivity?
Yeah, well, yes. And in fact, it's if you're one of those salt responders, salt supplementation makes your insulin sensitivity worse, right? And in the rest of in the 8.5 out of 10, it's going to make it better, right? So it's sort of it's individual, but it's super easy. Just do a salt washout, do your blood pressure like systematically twice a day, the same way. Compare it the next week after you add back salt, and you'll know, do I respond to salt? Or you can run the genes, or you could do both, right? But like that's a fraction of a thing, right? Like you know, you can pee out salt. You can pee out salt when your insulin's low.
Fast.
Yeah, correct. When your salt is low, you can pee out salt. Like you don't have to worry about the salt, right? So, 8 out of 10 people, so 4 out of 5 people will pee out a lot of salt to the point where you don't just get rid of the trash, the processed carbs, the sugar, the seed oils.
There's so many other questions. There's keto, there's low carb, there's carnivore. They're not all the same diets. Will you talk about some of those differences?
Yeah. So I mean, like, I don't know. It's like we give these terms to things, right? So it's the degree of metabolic dysfunction or autoimmunity would suggest the degree of drastic dietary measures, right? So the more metabolically unwell you are, the less activity you do, the more obesity you have, the more sort of the less inflammation you have, the degree of carbohydrate reduction you need is probably less. So maybe 100 grams of carbs a day works for you. And there are some people, highly active thin people. I think Paul Saladino is one of those examples where he includes a lot of carbs, but he's very active and he just feels better that way. I think if you
He's
have more,
careful about his carbs. Maple syrup, honey, watermelon, fresh fruit.
yeah,
He's pretty thoughtful about his carbs. It's not like he's ripping open a foil pack.
yeah, 100%. Yeah, but I think yes, it's a great caveat. Then the flip side is if your autoimmunity is through the roof and your metabolic disease is through the roof, like, carnivore may be a really good option for you, right? Just to eliminate and just to isolate, and then also the degree of carb restriction with carnivore. So I think it's just a spectrum and it's your goals, right? Like what is your goals? But the lever is the same. It's, eliminate crap out of the diet, and then the lever is the same. It's, the degree of carbohydrate reduction, and the lever is the same. The eliminate potential, co-conspirators. And then there's a bit of, a very small bit of that microbiome, I think needs to be also considered. It's just tough to consider it in a clinical setting, in my opinion, right now. But it's definitely a consideration. I think, I don't think it'll harm most people to do fermented foods. Probably is
I agree.
beneficial for most people to do fermented foods.
Glyphosate is in the news. I'm convinced that glyphosate will disrupt your gut microbiome. And I've been convinced by parents with autistic children that say getting the glyphosate out of their child's diet has improved their gut microbiome. It improves the profile of short chain fatty acids that are in their bloodstream, and it improves their neurological function. You might have a different opinion than me.
No, I think we're aligned. There's enough data to suggest taking it out helps, right?
Yep.
There's enough data to suggest. I think, we have to go back. Where does the burden of proof lie on? When you're dealing with a novel chronic exposure, the burden of proof is on the people financially incentivized to win, right? So Monsanto, Bayer, they need to prove safety. And the way they do it, the way they've lobbied the regulators is just bullshit. It's like the easiest way to quote unquote prove safety. It doesn't prove safety. It's just basically, proving safety is very difficult. And I think we need to determine, what that means for chronic exposures like these. And it doesn't mean like toxicity studies, right? That's not what this means, right? We're talking about potentially generational animal data. We're talking about long-term human consumption, voluntary human consumption compared to the alternative, and measuring very concrete outcomes, right? It's long-term animal studies, right?
Correct.
Oncologic animal
Whereas
studies.
these things are approved on an in vitro LD50. Okay.
Correct. Yeah,
That's not our concern.
correct. Yes. So the issue is a regulator issue, and it's again, we're dealing with decades of authoritarianism, paternalism, and science is great, and it is great. That's the other thing. It is great. It can be great. I mean, I always talk about Paul Thacker because I think he showed, and I wrote a piece. Paul Thacker is an investigative journalist, and but he always wasn't. He was on Capitol Hill leading, the Avandia and Actos issues from 2008 to 2010 when GlaxoSmithKline was found to be hiding cardiovascular data from their diabetes drugs, right? They had these drugs, Avandia and Actos. It was billion-dollar drugs. They were getting reports of negative consequences on the heart. They were hiding it, suppressing it, and they delayed it just to make money, essentially, and to investigate slowly, which is a very common pharma tactic. So they're not illegal, but it's not, it's not really ethical. So what he basically did in the end was that they were fined a multi-billion-dollar amount, but it was less than what they made. But what Paul Thacker did was he pushed industry to change. So the FDA, after those trials, changed the guidance to industry and said, we require cardiovascular outcomes trials for any diabetes, blood pressure or hypertension drug approved, right? We need for these, obesity, right? These drugs need to show that they reduce cardiovascular outcomes, not just surrogates, because we don't want another Avandia or Actos. And so he forced the regulators change. And this is what I want the people who are like, just corporate hacks out there to understand. It helps the companies when you increase the stakes. It helps them. Because look, we have drugs now that are even more widely adopted. A drug that makes you pee out sugar, right, is now one of the most widely adopted diabetes drugs. And you can reliably say you'll have less heart attacks on this drug if you have diabetes because they were forced to do the trial. That's why it's $1 billion study. And if you're, and look at Novo Nordisk and Eli Lilly with their GLP and GIP drugs, which compared to the old drugs we have are light years better. And I'm not saying to the average listener to go take these drugs. I'm not saying that. We take people off these drugs in our clinic. But compared to what we had, we know for 4 years, if you take, semaglutide or tirzepatide, these GLP-1 drugs, that you're going to have less heart attacks if you have severe obesity or if you have diabetes. So the level of data we have is so much better because we made industry show harder outcomes. And
Hmm.
I think that we should embrace that. And the companies out there listening to this should embrace that. Because if you show a real value to the population, right, and you make that value proposition more and more clear and more about the outcome, then the opportunity goes way up. These drugs have changed the trajectory of these companies. So if you're looking at, again, come back to models, right? The incentives have to align. And so if the regulators can align the incentives to what we all want, which is healthy and long-term living, right? The next step would be all-cause mortality, right? Show that people live longer on your drug, right? And people will take it. It'll
Humans
be
are
a
such
trillion-dollar drug.
long-lived animals. It's really difficult to do longevity research on human beings. Mice, you're fine, but that's decades of work to do the longitudinal
Whatever,
study to show
start with
people
5 years. Look, if there was a drug right now that did that, and I think tirzepatide and semaglutide could do it, right? If they pick the right population, really sick, really diabetic, and give this to them and measure all-cause mortality, I think that they would probably be able to do it within 5 years, right? At 5 years, I think that they would show a decrease in all-cause mortality if you pick a sick enough population. That's how sick we are, right? And I'm not crediting the drug, I'm crediting the sickness of our population,
right.
really, and selecting the right drug and the right patient.
That's been done with aspirin.
So that's a good point. It has not been done with aspirin, and we've reversed that. Aspirin's benefit is probably in those with a high CAC only and no
Mhm,
other bleeding risk, right?
mhm.
So, so just think about aspirin. It's a risk. You got to select the right population. If you have a significant degree of coronary disease, if the pipes are blocked here and there, and you don't have an otherwise notable bleeding risk, aspirin may benefit you, right? If you have nothing and your doc was just too lazy to check and blanket gave it to you, you're going to cause harm. So, look, bottom line is the incentives, and that's one thing I'm proud about. And I think if you're looking at it from the industry perspective, incentives is an opportunity. It's an opportunity. And so if I'm Bayer out there, the only reason to not want to do that study is if you know the outcome. And the only reason
Yeah.
not to change the regulator, right? And the regulators, if you know the outcome. If you're Eli Lilly right now and you're Novo Nordisk, you're like, yes, make everybody else show mortality benefit for diabetes because they know they can do it, right?
Yep. It's not necessarily regulatory capture, but companies with deep resources and a competitive advantage will advocate for stricter regulation because that creates a barrier to competition in a market that they're already advantaged in.
Bingo.
Not saying that that's wrong, but that's a different way of thinking about regulation than we might have thought about it. The thing about glyphosate for me is the benefit to the harm. Suppose we use glyphosate and it increases yields and reduce costs. What's our prize? More corn and soybeans? Like,
Yeah.
why do we even want that?
Yeah. I'll tell you why. We want that because of an ancient Roman saying. Oh gosh, what was it? Carnivals and
Yeah,
was it
bread and circuses.
bread and circuses? Yeah, that's the one.
Yeah.
That's why, right? Like you're a leader. You're like, are these people fed? Right, and that's about it. Right, that's your level of care. Right, if you're sort of way up there, and I think this immunity issue is a huge issue because those incentives are not
Great.
aligned. Right, and so we have to get rid of that as best
We're
as
not talking
possible
about immunity like a vaccine. We're talking about immunity from lawsuits. This is
for
what
glyphosate.
Aaron's
Yeah.
theory is going on about. Yeah.
Well, and
And
not
I
just that,
agree.
for glyphosate, there was an executive order giving them an immunity because this is a sort of national priority or whatever.
To onshore the production to make it in
Yeah,
the United States rather than overseas.
this is a terrible aligning of incentives. So I think we tack the incentive structure. We have to get corporations to understand that, get the corporations that are winning right now to agree, to tighten up and not give the ones that are hurting everybody immunity. Like that's the opposite of what you'd want to do.
I got one more question for you. Speaking of incentives, statins are probably the most lucrative class of drugs ever. What would it take for you to de-prescribe a patient who arrives at your practice and they're on statins?
Yeah, are you being harmed and do you want to take it? Like that's it. Are you being harmed from it and do you want to take it? Right? Like if I had a patient with elevated CKs, like, which is a muscle breakdown marker, and he was being told to just take it.
Hmm.
Just take it. Just deal with the fact that you feel miserable, you can't work out, right? Because
Hmm.
you're 40 and you have a LDL of 400. I think, there was a study that just came out. It was a modeling study that showed maybe, 1 out of 10 people benefit from the statin when they take it, right? And
That was
again,
too high. It was smaller than that. Yeah.
like let's just take the antibiotic example, because if you look at antibiotics, it's the same thing, right? A bunch of side effects, right? That you get. And what would trigger you to take an antibiotic if you feel that the infection is so severe that you cannot, it's sort of like a battle wound. Like when would you put a tourniquet on? You put the tourniquet, it has side effects. The tourniquet has side effects, but we use it because we assume our body can't. We make the judgment call. Our body may not be able to handle this, and we need to course correct. Right? We don't just go around putting on, tourniquets on every little wound. And that's what modern medicine has done with statins. That's what it's done with antibiotics. That's what it's doing with GLP-1s. I can design a patient that would benefit from statins. They have no insulin resistance. They have otherwise great mitochondrial function. They have a severe degree of stenosis in the arteries of the heart with plenty of soft plaque that they have no chance of reversing, and they have plenty of calcified plaque, and endothelial dysfunction genes, have high blood pressure, and plus or
Does that
minus a
patient
previous.
even exist?
Yes,
Like,
they exist. Yes, they exist.
okay.
Yes, they exist. I mean, they do exist, and these are the judgment calls, right? Like I will tell you, it's easy to say no statins because 9 out of 10 were inappropriately prescribed. Get a CAC, look at your vasculature. If you don't have anything, focus on the stuff that matters and just surveil. Stay off statin. You don't need to do anything. Like, I think the hard part becomes when you have disease, when you have risk, and you have to sort of make a judgment call, right? And I think so there are patients, I'll tell you, nobody would get a statin in my clinic without getting coenzyme Q10, without having their blood sugars monitored, without checking their CK, without, sort of seeing, and it would be the lowest dose, right? And I'm a wild, like, de-prescriber of statins. So just like you have to hear, I'm giving you the counterpoint. We are wild de-prescribers of statins. But there's cases when you'd use them, and I think that's a shared decision making. Like, here's the data. Like, you have a 20% risk. The harshest judges of statins say it's a 20% relative risk reduction. So your benefit of taking this over 10 years is going to be, about 4%. We can monitor for these bad things. What do you want to do? And some people are like, yeah, give it to me. So I think, like, that's the approach. I don't know, shared decision making, judicious use, appropriate use, thoughtful use. Look for the negative outcomes and
Oh, you don't
anticipate
sound
them.
anywhere near as radical as I thought you might be.
I don't know if that's good or bad. That could be both. Yeah.
Nick Norwitz has posted that he's doing cold plunges now. How about you?
Yeah, I've been doing this for a long time. I've been taking cold showers for, on and off. I haven't been as good this season, but on and off since I studied the literature behind Wim Hof maybe 10 years ago when he published the study in that German hospital. Yeah, 10 years of cold showers. Cold plunges were the only thing that helped my back pain, believe it or not. It was the only thing that helped my
I
back
believe
pain.
it.
Yeah.
Your back pain might be related to inflammation. cold exposure is really good for inflammation. Maybe you take the inflammation down and the pain goes away.
Yeah, yeah, yeah. If my back pain gets worse if I eat cashews, I mean, that's just me. I'm not generalizing, but if I eat cashews, my back pain's worse, and if I cold plunge, my back pain's better. Yeah, I do cold plunge, not regularly. You know, I have a trough, I fill it up in the winter, I let it freeze, I hit it with a jackhammer, and not a hammer, like a jackhammer,
Like a
a
sledgehammer. Yeah,
sledgehammer, and I'll do that, and my kids think I'm crazy, you know.
good for you.
So, yeah, I do like I don't do it as often as I want. I dropped the cold showers this season, but I gotta bring it back, you know? Every like, once in a while, I just keep the muscle alive, and I'll do the cold shower, but I used to do them a lot more often. I should get back to it, and you reminded me
I'm
to
in
get
there
back to it.
every day. My audience knows this about me. I'm in there every day. I'm not a super exerciser. I don't have abs like Saladino is. I'm a fat college professor, but I got a good triglyceride to HDL ratio. I've got excellent testosterone. A lot of the blood markers that would indicate good mitochondrial function are there. And I attribute that to the ice baths.
Yeah, it'll tell you if if you have back pain and nothing gets better, try it. I think for anxiety, it works, like the
Correct.
parasympathetic system and
Yep.
just the shock. So if you have anxiety and you need to just shock it or panic, I think it's like physiologically it makes sense to me. I think for mental health, it helps. I think probably on the metabolic side, there's positives, right? We are talking about brown fat before we started. I mean, I do it. Like, there's no what's the harm? Like you're
Well,
uncomfortable
I don't
for
know, Tro. Lane Norton says it's a dumb idea.
it's a you know what? I'll tell you if it's a dumb idea after resistance training, I think. That's the
I
like
agree.
immediately after. Yeah, yeah, yeah.
It's been
Look, it
great
was an
having you.
honor to be here. Thank you. It's nice to
Thank
meet
you.
you. I can't wait to come out to Arizona. If my life settles down a little bit, and hopefully that happens within the next 2 months, I'll get out there.
I'm
And
looking
thanks for
forward to
having me
having you
on.
out here. Yeah, this has been a pleasure.